And my other colleague, my co-chair, is Chema de la Torre. He's closer. He's from Santander, and he's an interventional cardiologist. So we have now a roundtable on diabetes and coronary care disease. I think the topic is exciting. It's the everyday practice. And we have the opportunity to share with you and with very known experts in this field, so in the expert of clinical and basic research and also in interventional cardiologist. So thank you very much, and Chema has a few words for you. Thank you.
Good afternoon to all of you. We appreciate your presence here at this time. It is difficult in Spain to keep the audience at this moment. Okay, we're going to start our session with the first topic, which is primary prevention and physiopathology of complications, cardiovascular complications in diabetic patients. We have Dr. Peter Grant, Professor Peter Grant. He comes from the University of Leeds in UK. He is responsible of the diabetology department in Leeds Teaching Hospital Trust. He is in charge of the Institute for Genetics, Health and Therapeutics, the Light Laboratories, and his focus is the diabetes type 2, but specifically genetic and environmental determinants of different factors like fibrin, structure and function in relation to insulin resistance. He's also, I think, is still the editor-in-chief for diabetes and vascular disease research. Okay. And he has hundreds of publications in Blood, Circulation, Lancet, all these kind of spectacular journals in the topic of diabetes. Then, please, we're pleased with your presence.
Well, thank you for that kind introduction, and thank you for giving me the opportunity to come and speak to you today on this topic. My title, you will see, is Primary Prevention and Pathophysiology of Cardiovascular Disease in Diabetes. I'm actually going to speak to you about it the other way around. So I'm going to talk about the pathophysiology of cardiovascular disease to start with, and then a little bit about primary prevention at the end. So let's start off very simply and ask the question, what is diabetes? And I think everybody knows really that it's a condition that's characterized by hyperglycemia and the long-term development of vascular problems. These vascular problems divide into microvascular disease, affecting the eyes, the nerves, and the kidneys, and of course macrovascular disease, of which cardiovascular complications is the most important. Type 1 diabetes occurs in young patients who are usually slim, they've lost weight, and they have absolute insulin deficiency because the beta cell ceases to function. As they progress through life, there's now a recognition that some of them develop insulin resistance as well if they put on weight a little later on. But early on, they only have the problem of insulin deficiency. Type 2 diabetes occurs in middle-aged overweight individuals, and they develop resistance to the action of insulin, which is subsequently followed by beta cell failure as the disease progresses. One of the common errors is to think that people treated with insulin always have type 1 diabetes, but many of our patients who have type 2 diabetes progress to needing insulin later on. Of course, there's an epidemic of diabetes facing the world at the present moment as it becomes westernized, and there are thought to be around 370 million people with diabetes by the year 2030, and at least the same number again have pre-diabetes. China alone currently has around 10% of its population thought to have diabetes, which is a staggering 100 million people. Only 0.5 to 1% of the total have type 1 diabetes, and the vast majority have type 2, which is what I'm going to concentrate on. A couple of hypotheses related to the development of type 2 diabetes and cardiovascular disease. The Thrifty genotype hypothesis was put forward in the 1960s by Neal, and he said that insulin resistance must have a survival advantage because it was so common, and he said that it was most likely related to periods of feast and famine historically. The common soil hypothesis says that diabetes and cardiovascular disease are the same condition. And what I hope to just show to you in the next 20 minutes or so is that insulin resistance, which physiologically should be short-lived in relation to obesity, becomes harmful when it's chronic and long-lived, leading to the development of diabetes and cardiovascular disease. The other thing that I think is worth recognizing about type 2 diabetes is the progressive nature of the disease, which is shown on this slide. If we regard this point, this dotted line, as the point when diabetes is diagnosed in an individual, it's now considered that there's up to 20 or 30 years of changes that are taking place prior to the diagnosis of diabetes that are contributing to the development of vascular complications. In this time, before the patient comes to the notice of a diabetologist or a cardiologist, there's a period of obesity-related insulin resistance shown here, a rise in insulin resistance with compensatory increases in insulin to prevent hyperglycemia. This keeps blood glucose levels in the near normal range. So for 20 years or so, we may have obese individuals who are insulin resistant but euglycemic. Something happens at about this time here when the beta cell loses the ability to continue secreting insulin to maintain euglycemia. Insulin levels fall away as the beta cell fails, glucose levels rise, and diabetes is diagnosed at this time. One of the things that's important to recognize is that in this period of time we have a combination of insulin resistance, which continues at this time, beta cell failure, and hyperglycemia. And it's these three things that make diabetes so difficult to manage effectively, because any one treatment is counteracted by one of the other features of diabetes. It's during this time often that patients end up on insulin as the beta cell fails, but because of insulin resistance, often they end up on very high doses and remain with relatively poor control in this time. The ticking clock hypothesis, put forward by Steve Hafner, suggests that in this period of time, when the patient is insulin resistant, the risk for cardiovascular disease commences. Risk of microvascular complications starts as the glucose levels rise and hyperglycemia supervenes, and there's further increased risk of cardiovascular disease as well. So this is very much a progressive disorder through the life of the individual. In 1988, Gerald Reaven at the Banting Lecture of the American Diabetes Association suggested that the reason diabetic patients got such a high risk of cardiovascular disease was because of clustering of atheromatous risk factors, shown here in yellow, around the presence of insulin resistance. This was a landmark idea at the time, but what I'm going to show you is that this has changed quite substantially over the last 20 or 30 years. The first thing to notice is that we've now recognized the role that obesity has in this process. This is a fat cell shown here, filled with lipid, which you can see triglyceride in green, and behind is the mitochondria in red and the nuclei in blue. And when the fat cell changes its phenotype, free fatty acids flow out from the fat cell into the tissue, attracting macrophages into the fat cell mass, and the macrophages release cytokines which have effects on the fat cell to release a whole range of proteins which initiate the process of insulin resistance. These proteins initially are working locally, but because fat in the overweight person is present in ectopic sites around blood vessels, in the heart, in the liver, there are effects of these proteins throughout the whole body which lead to the systemic development of insulin resistance. 20 or 30 years ago, diabetologists thought that insulin resistance only occurred in the cells that regulated metabolism, and glucose in particular. We now know that it also affects the cell systems which are involved in the development of cardiovascular disease. And I'm going to give a quick skip through some of these processes to give you some idea of what we think happens as cardiovascular disease develops. I'm just going to start, though, by reminding you of what you will know already, but that is the mechanism, if I can get this to work. Oh, yes. the mechanisms that are involved in the development of cardiovascular disease. And this video just shows a picture that many of you will have seen before, but it is blood coming down a coronary artery towards you. And here is the endothelium lining the arterial wall, and the first abnormality in people with coronary artery disease is the development of endothelial cell dysfunction, which leads to the adherence of macrophage monocytes, which migrate into the subendothelial layer to cause foam cell formation, fatty streaks, and early atheroma. That continues over many years, and you can see as the development of atheroma over this period of time, and the atheromatous plaque that's rich in macrophages and inflammatory changes will rupture, leading to the formation of a platelet-rich fibrin mesh, which is the thrombus that leads to myocardial infarction. This patient has an acute coronary syndrome now and is about to have a myocardial infarction as flow ceases. You all will know many of these things, of course, but the essential issue to see here is that there are multiple changes occurring over many years involving the endothelium, involving the macrophages, and involving clot formation. And in many ways, coronary artery disease is an inflammatory atherothrombotic process, with all of these processes being integrated and leading to the development of this final phenotype. If you look at people with diabetes and take out their atheroma, this is a paper published in Circulation some time ago now, but diabetes subjects who have atheroma have a greater lipid-rich area, they have more macrophage infiltration and more thrombus in their atheroma than their non-diabetic counterpart. So coronary artery disease is an inflammatory atherothrombotic process. In diabetes, the inflammatory atherothrombotic aspects of this disease are accentuated. If you look at the endothelium, which is the first abnormality that we see in people who are insulin resistant, the endothelium, shown here in cartoon form, generates nitric oxide through two mechanisms. One is a calcium-dependent receptor-based process, and the other acts through the insulin signaling pathway. And we now know that patients who are insulin resistant produce less nitric oxide. And of course, nitric oxide is a hormone that is a vasodilator, and also it has antiplatelet effects, protecting from thrombus formation. In the presence of insulin resistance, this very early change that occurs before the patient appears with diabetes or before they have any coronary artery disease causes increased tendency towards hypertension and increased tendency towards clot formation. At the same time, following on from this, the macrophage shown here, when it's insulin resistant, expresses a higher level of CD36, which is the LDL receptor. And oxidized LDL binds to that receptor, leading to the formation of foam cells. The insulin-resistant individual generates more CD36 and more foam cells than the non-insulin resistant individual. So as we go from endothelial cell dysfunction due to insulin resistance through to foam cell formation, it's underpinning the development of vascular damage. Insulin resistance is also associated with changes in the inflammatory pathway, with changes in C3 and CRP, which are the fluid phase of inflammation, and changes in the macrophage, which I've already mentioned, all of which contribute to the development of vascular damage and indeed thrombus formation. The platelet has a very important role in the final phenotype, as I showed in the cartoon. There are multiple pathways that are abnormal in people with diabetes. So hyperglycemia has effects on platelet reactivity, insulin resistance, reactive oxygen species, and inflammatory proteins themselves all affect the platelet reactivity. One of the interesting aspects that is just beginning to emerge is the role of CD36 in the platelet. You may recall a moment ago I said that CD36 was overexpressed in macrophages in people who are insulin resistant. There's now some evidence that it's also overexpressed in the platelet of insulin-resistant individuals, and that this receptor binds age proteins, which leads through a JNK2 pathway leads to increased platelet reactivity. So as you move from insulin resistance through to hyperglycemia, there's further increases in platelet reactivity and increased risk of thrombus. The platelet, when it's activated, and this is an activated platelet shown just here, expresses a range of ligands which bind to the monocyte macrophage, and the interaction between these two leads to the release of a further raft of pro-inflammatory and pro-thrombotic proteins. So as we move from insulin resistance through to diabetes, frank diabetes, there are inflammatory thrombotic interactions at all levels which promote vascular risk. If you want to know about platelets and diabetes, I suggest you Google Dr. Angiolillo, who's talking at this meeting, because he's done a number of important studies in this area. But this is just one that shows that platelet reactivity in people with type 2 diabetes seems to predict outcome. And this is a group of type 2 patients with stable coronary artery disease, followed up for 2 years for MACE, and MACE occurred in those patients who were in the upper quartile of platelet reactivity, suggesting what we probably intuitively knew, and that is that platelet reactivity has a very important role in thrombus formation in people with diabetes. The other side of the coin in developing an occlusive thrombus is the coagulation and fibrinolytic pathways. Now, the coagulation pathway is the process which is in place to develop fibrin. And you remember that in a coronary artery, it's an occlusive clot that's got fibrin-based that has platelets in excess. And this process leads to the formation of cross-linked fibrin when thrombin is generated and cleaves fibrinogen to develop this structure which binds platelets and other proteins. The other side of this coin is the fibrinolytic pathway, which lyses fibrin. And under normal circumstances, small amounts of fibrin are being made and broken down by the fibrinolytic pathway. In the presence of diabetes, there's a greater push towards fibrin formation, and this pathway is inhibited through a variety of processes. So the patient with diabetes produces a fibrin clot that is changed in structure. It's a more dense, tightly packed structure that's difficult to break down, it's less elastic, and it contributes to the phenotype of coronary artery disease when plaque rupture occurs. The fibrinolytic system is inhibited by this protein PI1, and if you look at patients with type 2 diabetes, they have higher levels of PI1, and they also have high levels when they're insulin resistant with less increase in glucose. So there's a stepwise increase in these proteins as people move towards diabetes. And as this increases, there's inhibition of lysis and loss of ability to break down a fibrin clot. The other thing is that glycemia itself has a direct effect on fibrin. This picture on this side shows the effects of glycemia on elasticity of a fibrin clot. So we've put little beads inside the fibrin that's taken up inside these fibrin strands, and you exert a magnetic field against that, and you get oscillations. And you can see that the presence of diabetes leads to fibrin which is unable to oscillate, which is much more rigid and less easy to break down. And that's accompanied by changes in fibrin structure that you can see here. This is reversible by improving glycemic control. When that happens, these are these pictures again. This is non-diabetic, this is a diabetic patient. When that happens, there are changes in fibrin's ability to bind the proteins that break it down. So there's increased binding of antiplasmin, decreased plasmin generation, and clot lysis is reduced by the structure generated in diabetes. So two things are happening. The fibrin's abnormal, and it's not allowing breakdown of the fibrin clot as it should do. If you look at the relationship between clot formation shown on this side and fibrinolysis shown on this side. This is a study we carried out in around 500 patients, and we categorized them according to number of cardiovascular risk factors that they had. And you can see as people get more risk factors, they get a more compact and dense fibrin structure, and they lose the ability to lyse the clot over a period of time. So this change in structure is moving with other cardiovascular risk factors. And the final thing that makes it analogous to the platelet is that when you look at all-cause mortality according to quartiles of measures of fibrin clot, you see that the highest, most densely packed fibrin structure is associated with the worst outcome in individuals who've had stroke. So fibrin, like platelet, seems to predict cardiovascular outcomes and is affected very much by the diabetes milieu. So in 1988, Gerald Reaven described the insulin-resistance syndrome as involving classical atheromatous risk factors, which I showed you in yellow. Since then, individuals have added the presence of obesity, which I briefly spoke about, and the mechanisms by which that contributes to cardiovascular risk and to the development of diabetes. There's also clustering of abnormalities in the fluid and cellular phases of inflammation and the fluid and cellular phases of thrombosis. And there are strong interactions between these two which further enhance cardiovascular risk. At this point, the insulin-resistance syndrome becomes an inflammatory atherothrombotic risk factor cluster. So in the risk factor levels in our patients are exactly mirroring what's happening in the coronary artery wall, leading to the development of inflammatory atherothrombotic disease in the coronary arteries. This has profound implications for the management and prevention of type 2 diabetes and, of course, the associated coronary artery disease. So the story so far is that diabetes and cardiovascular disease are the same condition, and it's underpinned by obesity-related insulin resistance. There's pro-atherogenic changes in a variety of the cell types associated with cardiovascular disease, endothelium, platelets and macrophages, and indeed in the cardiac myocyte as well, which I haven't covered. Alterations occur in thrombosis, inflammation, oxidative stress, and nitric oxide production. The progressive nature of type 2 diabetes is accompanied by progressive acquisition of cardiovascular risk, leading to this phenotype developing over many years. The implications for managing cardiovascular disease in the presence of diabetes are diverse. I'm not going to cover all of these by any means because, for example, lipid-lowering agents and blood pressure management will be very familiar to all of you, and I won't go through that. But I'm going to go through one or two things just finally before I finish. First of all, let's just look at weight loss, which is the cornerstone of management of type 2 diabetes, certainly in newly diagnosed type 2 patients, unfortunately rarely successful over a prolonged period of time. But we do know that if you lose weight, here's the mean change in risk factors per kilogram of weight loss. So if you were to lose 10 kilograms in weight, you would get a fall in systolic blood pressure on average of 6.8, a fall in diastolic blood pressure of 3.4 millimeters per mercury. It has beneficial effects on glucose, total cholesterol, LDL, HDL, etc. So weight loss does work, but unfortunately, generally, if it's done just through diet and exercise, it isn't maintained for prolonged periods of time. Following weight loss is glycemic control, and the basis of glycemic control being important is really based on its effects on microvascular disease. The Diabetes Control and Complications trial in 1993 showed that if you improved HbA1c, which is the measure of long-term glycemic control, you caused a massive reduction in eye disease. So a 2% fall in HbA1c, which is an achievable amount, was associated with a 76% fall in eye disease and a similar sort of improvement in nerve and kidney damage. That value was the one that led to the guidelines view that we should get to within 6.5 and 7% for people with diabetes because of this curve, which shows there's an exponential increase in risk as you rise above 7%, and you don't get much benefit below that in terms of eye disease, but you get much more hypoglycemia. That's been assumed to be a level that we should be aiming for in people with to prevent heart disease as well, but for reasons I'll show you, it hasn't quite worked out that way in relation to cardiovascular disease. This is a meta-analysis of what might be called primary prevention by glycemic control. I'm sorry, this doesn't show very clearly, but what it shows is 5 clinical trials carried out starting with UK-PDS and moving through to ACCORD. The meta-analysis is around 30,000 individuals, and looking at all of those trials, there's no effect of improving glycemic control on cardiovascular risk. However, what you can see is that moving from UK-PDS across to ACCORD, there's a clear difference in the outcomes of these trials, and it begs the question as to what actually is this telling us. Now, UK-PDS, of course, was a study which enrolled drug-naive type 2 diabetic patients, whereas ACCORD, which is the study which caused a lot of controversy, was carried out in patients who'd had diabetes for 10 years at the time that the trial was instigated, as was VADT. So if you look at these studies, which are actually increasing duration of diabetes across here, you see that they also had poorer glycemic control at the time that the trial started, both by HbA1c and by fasting plasma glucose, and that they were generally older as the trials moved across. Now, the UK-PDS has had a further 10-year follow-up after its original description in 1997, and it's shown that there's a persistent improvement in cardiovascular outcomes in individuals in this study, whereas over in ACCORD there was an increased death rate. Now, the ACCORD investigators don't seem very keen to take on the idea that this might have been hypoglycemia and associated dysrhythmias related to autonomic neuropathy, but that's what most of the diabetes world seems to think is the cause of the increased death rates in this population. And of course, in these other 2 studies, there wasn't benefit to them. So it seems that you get benefit if you treat early onset diabetes aggressively for glycemia, but you don't get benefit if you treat late on in the disease, because with comorbidities, they're likely to get other problems as well. That was supported to some extent by the DCCT EDICT study, and DCCT was originally set out to look at microvascular disease. It was carried out for 9 years and then stopped, and at 9 years you'll see this is cardiovascular risk in the conventional treatment and the intensive groups. After 9 years there was no benefit at all in terms of cardiovascular disease, but it appeared very much later. Now, this study was carried out in young people, followed up for many years, and it quite clearly shows that if you wait long enough, you get an improvement in outcomes by improving glycemic control. Very much what the UK-PDS study showed as well in type 2 diabetes. So it's led to the idea that if you're going to treat glycemic control in relation to cardiovascular outcomes, you have a window of opportunity shown here where you should be trying to treat intensively early on, and after that time you will hope to get the kind of benefits described in UK-PDS and DCCT. Wow. I don't know how that's happened at all. So just finally, to end on platelets, because clearly the platelet is an important target in the primary prevention of cardiovascular disease, certainly in the non-diabetes population. There are a number of pathways, of course, which you'll be familiar with, which are involved in platelet inhibition. But in terms of primary prevention, up to the last few years, we've been giving aspirin to our patients with type 2 diabetes as a primary prevention initiative. The trials meta-analyses that have been carried out in diabetes show no significant effect in prevention of cardiovascular disease in type 2 diabetes as opposed to the non-diabetic population, but does show a beneficial effect in secondary prevention. And there's a movement now in the guidelines towards suggesting that we should only be using aspirin in patients with diabetes in primary prevention if they're at high risk, which means having associated microalbuminuria or peripheral vascular disease. And I think diabetologists are moving away from giving aspirin as primary prevention because of the increased risk of major bleeds with little effect on outcome of vascular disease. So very finally, again, this is STENO2, and I think what we do now all know about cardiovascular disease in relation to diabetes is that clustering of risk is the most important issue. And STENO2 took a very high-risk population with microalbuminuria, and it treated for clustering of risk. It managed glucose, gave aspirin, blood pressure, lipids, and tried to achieve goals in each of those in this group of patients. And what you can see over 10 or 12 years follow-up is a marked improvement in outcome over that period of time. But the difference between this and glycemia is that the improvement starts to appear at 2 to 3 years with clustering of risk management, whereas all of the glycemic studies seem to show benefits at 10 years onwards. So improving clustering of risk management seems to be a critical part of primary prevention in people with type 2 diabetes. It's worth remembering that the life expectancy of someone with diabetes is dependent on the age at which they're diagnosed. So if you're diagnosed in your 60s, there's very little loss of life compared to a non-diabetic patient. The sort of benefits you get in patients with diabetes is very dependent on comorbidities. If a patient has multiple comorbidities, they get very little benefit by intensively treating glycemia and other cardiovascular risk factors. And what has happened in diabetes care is that we've tended to move now very much towards individualizing care according to the type of diabetes, the age of the patient, and the associated comorbidities. So thank you for listening to me. My conclusions are diabetes is characterized, as I started, by saying hyperglycemia and chronic vascular disease. Hyperglycemia relates very much to microvascular complications. Clustering of risks relates to heart disease. And heart disease itself, like type 2 diabetes, is a progressive disorder associated with a variety of abnormalities in the cells which regulate cardiovascular function. Diabetes and heart disease, at least untreated diabetes and heart disease, have common antecedents. And the management of the clustering of risk factors markedly reduces the incidence of complications. Thank you very much.